Hi everyone. In this part of lecture, we're going to expand our discussion on suicide to consider how this impacts us as healthcare workers and how we can be aware of and help implement prevention, intervention, and postvention strategies. Before we jump into all that though, we really do need to take some time to reflect on our own personal experiences, values, and beliefs surrounding suicide. When you think of suicide, what comes to mind? The death of someone you know, maybe a family member or friend or former classmate who died by suicide? Maybe something you saw on TV or in the movies. Something you may have contemplated yourself at one time or another. As you think about this, what types of feelings are you experiencing? Sadness? Anger? Relief? Confusion? We want and need to be aware of how our feelings and judgments about suicide impact the way we view it, because we have to be very careful not to let that influence how we interact with our patients or their families. Depending upon your healthcare discipline, and maybe even the organization you end up working for, there might be very strict policies or a stance taken on suicide and how ideations, attempts, and deaths are to be handled. Our previous lecture explored how society views suicide in different circumstances, and we see a common theme emerging, and that is of intervention. We feel as though we not only morally, but also legally have an obligation to try to keep people safe, whether that means they threaten to hurt themselves or someone else. We see it as our role in healthcare to reach out and offer our assistance, to refer our patients for counseling or other therapeutic relationships to help them learn to cope with life stressors that they're experiencing. The medical model considers suicidal behavior as abnormal and as in need of intervention, and this is then reflected in our policies, procedures, and even laws like mandatory reporting. That's fine and dandy from a formal perspective, but suicide touches people very personally, including the healthcare team. Let's consider a couple of situations that may happen and how you might respond. You're a nurse in the emergency department. You saw the squad bring in a 45-year-old male and heard the EMT report of a hanging victim. The staff are currently trying to resuscitate him. Then you see a woman screaming in the waiting room and you're called to deal with her. You are told that she is the patient's wife, who found him in their home when she came home with their 3 children, ages 4, 8, and 15. What do you do with her? How do you react? What do you say? What should you watch for? Take some time, push pause, and really think about this. What types of things might you say or ask? What might you be thinking in terms of resources available to help them? How can you address their immediate needs and concerns? Push pause and take a few minutes to consider these things. And when you're ready, push play to continue. Here's a different scenario. Let's think about what you might do or say or how you might react in this case now. You are the nurse in the NICU, having worked with a family for the past 2 weeks. The mother has been having issues with postpartum depression, and the father of the baby is doing his best to work, pay the bills, visit their premature baby, and support his wife. He calls the hospital frantic, saying he found his wife in the garage with the car running. He states that she has died. How do you react? What do you say to him? What should you watch for next time you see him? Is there anything you should do? Wow, right? These situations are never easy, and we never feel fully prepared to jump right in and have the perfect response at a time like this. But that's exactly why we think about it now, ahead of time. So we do have at least a couple of ideas of things that we want to do or not do in order to help. What do you think would be best in this situation? Take a few minutes to think about this one as well. and then push play when you're ready to continue. Why else is it important that healthcare staff are aware of and involved in helping provide emotional support to patients who might be suicidal? Well, here's a whole list of reasons why. Primary healthcare staff have a long and close contact with the community, and they're usually well accepted by local people. In other words, people already know them and trust them. They'll know you and trust you, especially if you're in the same place for a long time or a smaller community. Healthcare workers provide the vital link between the community and the larger healthcare system. They're the liaisons, if you will, and can help bridge that gap in communication and support that so often exists. In areas where mental health services are not well developed, they are oftentimes the primary source of healthcare. We see this in urban areas, but especially in rural areas, where there's just not many mental health supports available for everyone. And if there is, not everyone can afford to pay lots of money to see a therapist, or they may not have insurance or good insurance coverage, and thus the nurse and doctor often become the go-to people that they seek out for mental health support. Healthcare workers' knowledge of the community enables them to gather support from family, friends, and also organizations. They know what's available and how to access it, which is critical since most hospitals, clinics, and other healthcare entities won't have a social worker. The healthcare team members are the ones who make most of those referrals and connect patients with the services they need. Also, primary healthcare staff are in a position to offer continuity of care. They can see that person regularly, or may have another way to check in on them and see how they're doing. They're often the entry point to health services for people in distress. In short, you as a healthcare worker are available, you're accessible, knowledgeable, and hopefully committed to providing care. Even so, in situations like the two scenarios we looked at just a moment ago, it's hard to know what's most helpful in that moment of crisis. We're not there to judge or second guess the person that died or the family that found them and is now thrust into grief and chaos. We're not there to provide hindsight and make them feel guilty for something that they think they should have seen or noticed or done. But we do need to know that some indications and clues of suicide exist, what those might be, so that we can recognize them when we see them, whether in patients, family members, friends, colleagues, or even ourselves. It helps us if we can try to understand the state of mind that someone is usually in when they're suicidal. 3 features in particular are characteristic of the state of mind of suicidal patients. First, we see ambivalence. This is the fact that many people have mixed feelings about committing suicide. The wish to live and the wish to die wage a seesaw battle back and forth in that suicidal individual. There's an urge to get away from the pain of living and an undercurrent of the desire to live. Many suicidal people don't really want to die. It's just that they're unhappy with their life. If support is given and the wish to live is increased, the suicidal risk is thus decreased. Second, we see impulsivity. Suicide is also an impulsive act many times. Like any other impulse, the impulse to commit suicide is transient and it lasts for a few minutes or maybe a few hours. It's usually triggered by negative day-to-day events. By diffusing such crises and by playing for time, the healthcare worker can help to reduce the suicide wish. 3 is rigidity. When people are suicidal, their thinking, feelings, and actions are constricted. They constantly think about suicide and they're unable to perceive another way out of that problem. They think drastically. A majority of suicidal people communicate their thoughts and intentions. They often send out signals or make statements about wanting to die, feeling useless, or so on. All of those pleas for help must not be ignored. When the primary healthcare staff suspect that suicidal behavior is a possibility, the following factors need to be assessed. First is the current mental state and the person's thoughts about death or suicide. How are they acting? How are they feeling? Are they actively considering suicide? Then you look at what their current suicide plan is. How prepared are they? How soon is the act to be done? Do they have a plan for when they'll do it, how they'll do it? Do they have the means already, such as guns, knives, pills, rope, car, or whatever method they're planning on using? Finally, we want to assess that person's support system. Do they have family or friends who are involved and available to help them? Or does the person feel isolated and not have anyone to reach out to? So how do we ask? I mean, it's not easy to talk to a person or ask a person about his or her suicidal ideations, but it's important that we do so. It's helpful to lead into the topic gradually. Some useful questions are, do you feel sad? Do you feel like no one cares about you? Do you feel that life is not worth living anymore? Do you feel like dying by suicide? So how do we know when it's the best time for us to ask these questions? Maybe when the person has a feeling of being understood, or when they're comfortable talking about how they're feeling. Or maybe that person is talking about negative feelings of loneliness and helplessness, and that might be a good opportunity for us. So what exactly do we ask as we're assessing their risk? Well, if we're trying to find out whether the person has a definite plan to commit suicide, try these. Have you made any plans to end your life? Do you have an idea of how you're going to do it? To try to find out whether or not the person has the means or method, just ask. Do you have pills, a gun, insecticide, poison, whatever other means? Is that readily available to you? To find out if the person has a fixed time frame in mind, ask, have you decided when you plan to end your life? Or when are you planning to do it? Even though it may be awkward, ultimately the best way to find out whether individuals have suicidal thoughts is just to ask them. Contrary to popular belief, talking about suicide does not plant the idea in people's heads. In fact, most people are really grateful and relieved to be able to talk openly about the issues and questions that they are struggling with. Why might we be worried about them in the first place? What might they say or do that gives us an indication that there's a problem or we need to be concerned about their safety? There are different types of indications that someone may be experiencing a suicidal crisis. The first one is verbal direct, which is where someone makes an actual statement about killing themselves. They may come right out and say that they wish they were dead, or I'm better off dead, or that they're thinking of ending their life. Other people are more vague in how they word it, which is an example of verbal indirect indications. Maybe they say something like, it's just not worth it anymore, or the world would be better off without me, or things would be easier for everyone if I just weren't here causing problems anymore. This sends a clear message that they're really struggling, that they're feeling helpless or hopeless, as though things aren't ever going to get better. Then we have behavioral indications as well. A direct behavioral indication would be taking actions to get ready to kill yourself, such as locating a gun or a knife or a rope, or maybe writing a suicide note. Indirect behavioral indications, then, may include making a list of items that you want to give away to others, or making posts or drawings about death or pain or suffering that's never ending. The point is not that we get overly stressed about what category the verbal or behavioral messages fall into, but rather that we're aware that all of these things are indications that a person may be reaching their breaking point, and suicide may be seen as a very real, if not the only option left available to them. These are big red flags that we have to know to look out for. To explore these in more depth, here we see some examples of possible verbal statement clues that people may give if they're considering attempting suicide. For example, if they're sad or depressed, they may say or think, I wish I were dead. If they're lonely, I can't do anything. If they're helpless, I can't take it anymore. If they're hopeless, I'm a loser and a burden. If they're feeling worthless, others will be happier without me. These are just some examples, but as always, we want to also be watching for those indicators that the person is feeling helpless or hopeless. Similarly, here are some other possible behavioral clues that someone may be experiencing a crisis and may be considering suicide. I know this is a lengthy list, but listen as I read them out loud. Do they have withdrawn behavior or an inability to relate to family and friends? Are they suffering from a psychiatric illness? Is there alcoholism or drug use involved? Do they experience anxiety or panic attacks? Have you noticed a change in their personality, maybe showing more irritability, pessimism, depression, or even apathy? Have you noticed a change in eating or sleeping habits? Have they made a prior suicide attempt? Do they express feeling self-hatred, feelings of guilt, worthlessness, or shame? Have they had a recent major loss, such as a death? Have they gone through a separation or a divorce, loss of job? Is there a family history of suicide? Do they seem to have a sudden desire to tidy up their personal affairs, write a will, or other things like that? Are they feeling lonely, helpless, hopeless? Have they left a suicide note? Are they sick physically, ill with a chronic or debilitating disease or condition? Have they repeatedly mentioned death or suicide recently? And as we see in the bottom in that purple box, ultimately the presence of both alcoholism and depression is one of the most significant factors that increases the risk of suicide. Of course, these verbal and behavioral clues aren't the only ones that someone may exhibit, but they're certainly some of the more common ones. It's also important, as we see on this last bullet item here, that sometimes people seem very down and depressed, but then suddenly and strangely seem to be really happy and content all of a sudden. This can actually be a big warning sign that they've already made their plan to die by suicide. They finally feel happiness and relief knowing that the end is coming, and they soon will no longer be suffering. This can be very confusing, though, for family members and friends who after the fact say it just didn't make sense because that person seemed to be doing so much better that day or those few days before they died. As we're learning to recognize signs and symptoms that someone may be considering suicide, we at the same time need to address many of the common myths that circulate in our society. Here are some of the most common myths or misconceptions that people assume are accurate. However, they're very false, and we'll look briefly at each. First, there's this idea that people who talk about suicide don't attempt suicide, and that's not true. Almost 3/4 of people who eventually kill themselves have given some hint ahead of time. This myth just encourages people to ignore cries for help. Suicidal people are fully intent on dying. Again, not true. Most people who attempt suicide do not actually end up dying from suicide. We learned earlier that there are 25 attempts for every one completed suicide in the US, so clearly not everyone keeps trying and trying until they die. Many get help along the way. In fact, someone may have decided that they want to die, but then right before they go through with it, they change their mind. A suicide attempt doesn't necessarily mean the person actually wants to die. Next, we see the myth that only people in certain socioeconomic classes will die by suicide. No, people in all income brackets take their own lives, so we can't assume it's only the poor, or only the middle class, or only the wealthy. There's a long-held misconception that asking people about suicide will only encourage them to do it. Really? No. The opposite is true, actually, as many lives have been saved by people caring enough to actually ask the person directly. Sometimes all they need is someone to talk to, someone to act like they care or they understand, and that may be enough to prompt them to get the help they need. Finally, there's a myth that only crazy people die by suicide. First of all, the term crazy is judgmental and highly unprofessional, so please don't ever say it about your patients. We do know that many people who attempt suicide really do suffer from mental illness, like depression or other mood disorders, anxiety, or even psychosis. But there are other people who are just so overwhelmed by circumstances that they see suicide as their only option. One other thing that I learned many years ago in my work with grieving families at Teddy Bear Hollow was to be aware of how we talk about suicide. It's a work in progress for all of us, including myself, but we can change our language to sound more factual and less judgmental. People die all kinds of ways. People die from cancer, people die from heart attacks, people die from strokes, and people die by suicide. When we say commit suicide, it equates a moral judgment and assigns blame for a sin or a crime that was committed. Even if you personally believe that suicide is a sin and you can't go to heaven, it's not your place to push those views on the family members who are dealing with their crisis and grief. By changing our wording to died by suicide, it calls it what it is, the reason or the way the person died, and it doesn't have to get into assigning blame or condemnation. Some people want to be more specific, and depending upon the age of any children involved, they may explain it in different ways. If the kids are older or all grown up, they may just say, Dad shot himself, or Mom left the car running in the garage, and that's how they died. Or they may focus on the mental health aspect and explain, Grandma had depression. Her heart hurt too much after Grandpa died. She didn't know how to take away the pain of missing him. Only now we're left to miss her too. If the kids are younger, they may explain that Grandma died of a broken heart. It's important, though, that if you use these other ways to explain it to children, that you always have to have a disclaimer on it. You literally need to tell the kids that it's not the same as when they are sad, or when they're lonely, or if they fall outside and it hurts their tummy. Maybe you need to say, Grandma had a hurt that wouldn't go away, and she wasn't able to ask for help. Or Grandma was so sick that her brain didn't work the same way it used to, that she couldn't make decisions clearly. When you get hurt, though, or if you have a headache, any other problem, you need to always let me know, or another grown-up know, so we're here to help you. That's very important. Otherwise, children equate what happened to the other person and assume that might happen to them as well. As mentioned a moment ago, there's usually a type of progression or steps that are taken as someone moves from just considering suicide as an option to formulating a plan, to acquiring the means or method for how they will die, and then using that to make the actual suicide attempt. The idea is that if we can recognize these signs and symptoms early enough, we may be able to intervene before it's too late. Our attempts to reduce the number of deaths by suicide thus fall into three categories: prevention, intervention, and postvention. Let's take a look at each. Many suicides can be prevented. We need to be aware of signs and symptoms so we know when to intervene, but prevention comes even before that. For starters, we need to reinforce opportunities throughout childhood and adolescence to teach coping skills. We've seen a real decrease in coping skills for younger generations, so even helping kids face adversity during the younger years and the teenage years will help them develop the tools they need to handle change, disappointments, and failures when it's on a smaller scale and it doesn't yet involve life or death decisions. We need to send the message that it's okay to struggle, it's okay to fail, and there are things we can do so that we do better next time. Life isn't perfect. It certainly doesn't have to be all or nothing. Coping skills that we teach and model to people growing up can go a long way in preventing all kinds of physical and mental health problems. We need to teach self-care so people know how to take care of themselves, but we also need to teach resiliency, which is what they need in order to get back up when they've been knocked down. Second, we need to be knowledgeable of resources available in our own communities, and then make the public aware that these resources exist and how to access them. Examples may include hotlines and crisis centers, counseling agencies, maybe those that offer sliding scale fees for service, members of the clergy or faith groups, resources at middle schools, high schools, colleges, even places of employment. And at the same time, we need to be aware that there are some very real physical barriers that make it hard for people to access those resources. Think about it. Lack of money or insurance, time, transportation, childcare, even physical disabilities or mental illness can make it nearly impossible for some people to reach out and access the services they need. Doing what we can to help them access that care and support is critical. We need to focus on this person who cannot decide whether or not they want to live or die, this person who's struggling and just doesn't know what to do. Very often when people say, "I'm tired of life," or "there's no point in living," they're just brushed off, or they're given examples of other people who have been in worse situations. Neither of these responses actually helps that person who's suicidal. The initial contact with the suicidal person is very important. Oftentimes, the contact occurs initially in a busy clinic, a home, or a public place where it may be difficult to have a private conversation. The first step, then, is to find a suitable place where a quiet conversation can be held in private. The next step is to allocate the necessary time. Suicidal people often need more time to unburden themselves, and one must be mentally prepared to give them the time they need. The most important task is then to listen to them effectively. To reach out and listen is itself a major step in reducing the level of suicidal despair. The goal then is to bridge the gap that was created by mistrust, despair, and loss of hope, and then give the person the hope that things could change for the better. As you're talking with that person, here are some very concrete examples of things to do and things not to do. I ask that right now you push pause and slowly read through each item in the do column first. Why might these things be helpful and important? Then look at the don't column. Why would we want to avoid doing these things? What may happen if we did? So push pause and read through both of these lists, taking time to consider each carefully. Now that you've considered each, what are some basic takeaway points? Be direct. Talk matter-of-factly about suicide. Listen. Allow them to express their feelings. Don't act shocked. Don't lecture them on the value of life. That being said, you can offer hope that alternatives to suicide can help. If you're able to, try to remove their means, such as guns or stockpiled pills. Don't allow yourself to be sworn to secrecy, as that's not really helping them. Ask them if they can make a contract for their safety. If they can't, and they can't promise that they won't attempt suicide, then you need to get them help immediately. You need to contact people or agencies that are trained in suicide prevention, such as a doctor, a therapist, or you may even need to have them hospitalized for treatment so they don't harm themselves. In the end, your goal is to listen with warmth, treat them with respect, empathize with their emotions, and provide care with confidence. You can make a difference, and you can help them access the support services they need. If a suicide occurs, You and the clinic or the hospital or whatever setting you're in needs to take steps to immediately address the death. You can expect that there will be some resistance for people to open up and talk about what happened. The family might be resistant, maybe the first responders who were there on scene, or the emergency department team may be a bit resistant at first. Allow them time to explore their emotions and to process what happened. For some, they may not believe it's real yet. Remember, our minds have that normal, natural bit of denial at first when something traumatic has happened. It's important that you have information ready to refer them to appropriate personnel or agencies to deal with what's happened and to process their thoughts, experiences, and feelings. As with any death, avoid cliches. We tend to say things to try to make people feel better or ourselves feel better, but oftentimes nothing really comes out right. Sometimes just saying, "I can't imagine the pain you're in right now," or "This is so sad," or "I want to help, but I don't know what to say and I don't know what to do." Those comments acknowledge their pain in the moment, and you're not trying to tell them how to feel or what they have to do next. Depending on what happened, and if this was a patient who died by suicide, or maybe a coworker, supervisor, or administrator at your place of work, you'll want to have a team put together a comprehensive plan for support. Many places have a crisis team that comes together in the event of suicide or other death or trauma, and they'll know how to put together a holistic plan to help everyone cope with the loss. In the end, there are a lot of things we can do. Nothing is ever 100% effective in stopping every single suicide, but being aware of the risk factors, being willing to reach out and connect with people who are hurting, and being able to tap into their resources that are there can really put us in a good position to reduce the number of people who feel that suicide is their only option. In the end, the most important tool in the prevention of suicide is the establishment of a meaningful interpersonal relationship and the subsequent exploration of the patient's life stressors, conflicts, and feelings. Your role in healthcare may very well put you in the position to be that difference maker, that person who can take a few extra minutes to listen, to acknowledge, and then make referrals when necessary. It's not meant to feel like a burden, but rather an opportunity to save lives.